Good evening, and I welcome all of you for this webinar, which we are having on the fast track surgery, a multimodal approach for better outcome. I'll just give you a brief about Navya. Navya is a cancer informatics and patient services company. We use technology and the guidelines, national cancer guidelines and the international cancer guidelines, which with the help of that, we provide personalized evidence-based cancer treatment plans along with the help of the Tata Memorial Center and National Cancer Grid experts for the reference of the patients and the physician who are treating the patients. And as a part of our relationship with the physicians, we conduct these academic sessions where the experts of Tata Memorial Center and National Cancer Grid share their experience with the participants and other oncologists who are here. And that will be ending as a discussion and then interactive session, which will be helpful for the clinical practice. Now, we reached out to the panel of experts from the Tata Memorial Hospital, Dr. Mahendra Pal, Dr. Sukhada Savarkar, Dr. Amandeep Arora, Dr. Sarika Mahajan, and Dr. Shivshankar. And I welcome you all. I welcome all the panel of experts. And when we requested them for having a webinar for the benefit of all the oncologists and other physicians, so they accepted our invitation and they agreed to conduct this webinar. I thank all of them wholeheartedly, and I welcome all of you for this webinar. Now, the agenda of the webinar is simple. After this welcome invitation, introduction of the faculty and the topic will be done by Dr. Mahendra Pal. Then Dr. Sukhada Savarkar will take us through the anesthetist perspective on fast track surgery. Dr. Amandeep Arora will speak about fast track surgery or tracking of safety during surgery. Then Dr. Sarika Mahajan will speak about the importance of physiotherapy in fast track surgery. And Dr. Shivshankar will take us through the impact of nutrition in fast track surgery. In this entire process, we will have the introduction, then we have the fast track surgery presentations from each panel member, followed by a case discussion and a panel discussion, which will be moderated by Dr. Mahendra Pal. And further to that, we will have the interactive session, wherein the participant will have the opportunity to speak and clarify their doubts with the panelists. So till that time, we will. I request all of you to be on mute, and then please listen to the panelists. And if you have any questions, you can please post it in the chat box so that we can address it during the discussion itself. So now I welcome Dr. Mahendra Pal to take the discussion forward from here. Sir, over to you, sir.
Yeah, thank you, Dr. Naga and Navya, for giving me this opportunity. Just a brief, it was my pleasure to, whenever I approached Dr. Sukhda, Dr. Amandeep, and Dr. Sarika and Dr. Shiv, when I told them about this webinar, and immediately they did not think about that, and they just immediately say, yes, this is the important topic, and as a surgeon, we should be doing something for it. And what is the importance of this topic? So coming to our topic is that earlier, before the fast track surgery was introduced, so the principle of surgery in the past were like it initiates the complex stress response, which can lead to pain, nausea, ileus, and impaired pulmonary function, increase cardiac demand, and require prolonged hospital stay. In the past, our main focus was to have a maximum comfort for the patient, and we did not bother about the hospital stay and other parameters. So in the past, we have the principal surgery was the pre-operative prolonged fasting. That suppose if any patient has a bowel surgery, we should not allow him to take orally because it may affect the bowel leak and the bowel mobility. Mechanical bowel preparation, use of nasogastric tube, empty the bladder for longer duration, and intraoperative contamination, giving antibiotics preoperatively to reduce the bacteria burden, and prevent early passage of bowel content to the anastomotic sutures, and the prolonged bed rest for the same reason that we used to thought about that if the more rest we will give, patient will have more comfort. Next slide, please. So Dr. Henrik in 2002, he introduced the concept of fast track surgery, also known as enhanced recovery after surgery. And the aim of fast track surgery was to reduce perioperative stress response and organ dysfunction, reduce incidence of post-operative complication, and that results in faster recovery to return to routine life, and it also indirectly it has a reduced cost and duration of hospital stay required. Next slide, please. Implementation, as we know, it is not a one-man show, it is a teamwork, and it includes a surgeon, anesthetist, physiotherapist, dietitian, nurses, and overall, they all have to do proper counseling and education for the patient. And this planning has a three-phase, like pre-operative, intraoperative, and post-operative. So it is a multidisciplinary approach, and usual composition of the team fast track surgery are very important, and each and every step, their contribution cannot be ignored. Next slide. So coming to the job of the different disciplines, like surgeons, they have to select appropriate trim, use manual techniques, avoid tubes and drain, ensure early mobilization and feeding, anesthesia, suitable anesthesia, fluid management, pain care, and physiotherapist, early mobilization, rehabilitation, before surgery, during surgery, and after the surgery. Dietitian, again, they have to assess the patient pre-operatively, and accordingly, they have to give diet recommendation post-operatively. So we are going to have these parameters will be covered by all our specialists. And also we should not ignore that patient relative must be involved in each step for the better result for this multidisciplinary approach. Next slide. Now we should go with the our talks. So I would like to invite Dr. Sukhda, who is the senior anesthetist in our department, and generally we discuss about the patient before the surgery as a routine for the better outcome. And let's see how what is the anesthetist perspective towards fast track surgery. Dr. Sukhda, please share your slides.
Thank you, Dr. Mahendra. Can I share my slides?
Yeah, sure.
Thank you, Dr. Mahendra. So Dr. Mahendra has already discussed about the genesis of fast track program and enhanced recovery program, and also the components of ERAS. So I won't go into the details of that. So I'll basically talk about the anesthesia perspective in enhanced recovery program. The aim of my presentation will be to know the exact role of anesthesiologist in the perioperative period, also to see the various components and interventions to be taken in the preoperative, intraoperative, and postoperative period. Also, what are the areas where you have further scope for research, and what are the controversies which are involved with anesthesia interventions. So let's talk about the perioperative period. So there are 4 or 5 components which are really important from anesthesia perspective. So the patient education, assessment of comorbidities and their risk stratification, their optimization, and preoperative fasting and pre-medication. So as far as patient education is concerned, it is of the utmost important aspect of the preoperative period, because we have to explain the patient in detail about every step of the perioperative period, what are the risks involved because of the surgery and because of the presence of comorbidities of the patient. And also it is important to, set some real expectations about the post-op recovery. We should not paint a very rosy and a fairy tale picture, because patient will find it very hard in the post-operative period if the expectations are not met, and it will affect the patient's recovery. Also, often we forget to explain all the possible pain relief options to the patient. For example, there can be epidural analgesia or fentanyl PCA or any other facial pain blocks. So we need to explain the risks, pros and cons of all the options, and the patient should ultimately decide what kind of a pain management the patient wants. And also the preoperative medications, fastings, we have to explain to the patient. Then next important part is identifying the comorbidities and stratifying the risk according to them. So the most important factor here will be to see what are the modifiable factors and non-modifiable factors. So for example, if the patient is hypertensive, it is a non-modifiable factor. But if you can modify the dosages of the medications, or if you can reduce the hypertension response, or if it is uncontrolled, you can increase the dosages, that will be something which is modifiable. There are various scoring systems, but the most important scoring systems I'll just tell you in detail. The most famous and the most commonly used classification is ASA, anesthesia classification scoring system, which we use to see the risk associated with the patient comorbidities and surgery. Then there are certain cardiovascular risk calculators which we can use if the patient is having coronary artery disease, or if the patient is at high risk of cardiac complications. Apart from that, we should assess the risk of acute kidney injury postoperatively. And last but not the least, we need to see the functional capacity of the patient. So as far as ASA classification goes, because I'm sure everyone must have heard ASA classification, I'll just give a simple example. ASA 1 means healthy patient, no comorbidities, no addictions. ASA 2 means if the same patient develops hypertension. ASA 3 will be the same patient, but now the patient has uncontrolled hypertension, or patient has history of MI because of that hypertension. ASA 4 will be if the patient has had MI in the recent past, which is less than 3 months. ASA 5 is a patient with MI, with cardiogenic shock, and with organ dysfunction, who is probably requiring intensive care in the ICU. And ASA 6 is a brain dead patient. So higher the ASA grade, higher the risk associated for the patient for postoperative complications. So this is how we assess the risk of the patient. Apart from that, as I said, the functional capacity assessment is very important, and it is measured in terms of metabolic equivalent. So for example, if the patient can climb 1 flight of stairs, it is generally equivalent to 4 metabolic equivalents. And if the patient can do farming or can play tennis or something, then it is a very good functional capacity of the patient, which is equivalent to 10 METs. Okay, if the patient is not able to perform even 1 flight of climbing of stairs, then it is considered to be poor functional capacity. In that case, probably we need further testing, or in some special cases where patient is already a cardiac patient, we need further testing in terms of either a stress test or a dobutamine stress test or perfusion scanning, etc. Then there is dynamic testing, because all these are subjective testing. Patient can say he can climb 3 flights, but we never know whether he's actually saying it correctly or not. So we can actually do objective tests like 6-minute walk testing, or CPET, which is cardiopulmonary exercise testing. So there are set goals and set objectives, and we can assess the functional capacity according to that. Last but not the least, again, this is not to cancel the surgery. This is not to decide whether, we can operate or not. This is to say whether the patient will have higher rate of complications, higher morbidity, and how we can optimize it and reduce it. So the next part is optimization. So 3-4 aspects are very, very important. If the patient has alcohol or smoking addiction, it has to be, the patient has to be asked to refrain from it at least for a month. The studies have shown that at least a month of abstinence from smoking and alcohol increases the recovery of the patient. Also anemia correction, not just by blood transfusion, but by IV or oral iron tablets, folate and B12 correction. This is very important before surgery. Then all other comorbidity optimization by reviewing the medication, increasing or decreasing the dosages of that. If the patient is diabetic, we need to control the sugars at least less than 200 milligram per DL preoperatively. Initially, the concept was to have a very tight control of sugars, but now it is not considered very safe because there are more complications with respect to hypoglycemia. So less than 200 is acceptable before surgery. And frailty assessment. Now, frailty assessment is coming more and more in picture because that is something which is important for post-op recovery. And here, the role of nutritionist and physiotherapist is very, very important, and I'm sure they will talk about it. So basically what we are doing in this period is increasing the functional capacity of the patient even before the surgery has started, so that the dip of the functional capacity, which happens because of surgery and stress of the surgery, will recover much faster, right? Then comes the preoperative fasting. Now, the traditional view was to keep the patient fasted for overnight for 12 hours, 10 hours. Now, the latest guidelines recommend 2 hours fasting for clear liquids and 6 hours fasting for solids, right? And if you keep a prolonged fasting guideline, it does cause harm, in fact, because it inhibits the insulin secretion and it releases catabolic hormones, causes insulin resistance, etc. And basically, it can be harmful in the postoperative period. and in the intraoperative period also. So the recommendation from IRA Society is to give a oral carbohydrate load like maltodextrin, 800 ml before, night before surgery, and 400 ml 2 to 3 hours before surgery. We actually do give Appy, which is a clear Appy juice in our hospital 2 hours before surgery and also at night. Now, can we give it to all patients? Maybe there are not enough studies and recommendations for all patients, but by and large, all patients can take it except if the patient has documented delayed gastric emptying or bowel obstruction or insulin-dependent diabetes or morbid obesity, then probably we need to avoid it till further studies are available. Then about pre-anesthetic medications. Now, generally the guidelines are not having any strong recommendations for any pre-anesthetic medications. For example, midazolam or opioids before surgery for anxiety reduction. If the patient is well educated, well counseled, the anxiety itself is less before the surgery. But if you have to give, yes, then you can give a very short acting benzodiazepine like midazolam or fentanyl before doing any procedure or inserting epidural, etc. But we need to avoid it in elderly patients more than 60 years because it has shown to increase the incidence of delirium and cognitive dysfunction in post-operative period. Regarding other drugs, there are many drugs which are tested: beta blockers, alpha agonists, clonidine, gabapentin, paracetamol, but there is no strong recommendation for any of the drugs yet. Then coming to the intraoperative component. So what are the most important components where we can actually change our techniques? First is the technique of anesthesia, whether you give GA or regional, whether you give inhalational anesthesia, that is sevoflurane, isoflurane, or whether you give a total intravenous anesthesia in the form of propofol infusion. Then the prevention of nausea and vomiting, then temperature regulation, avoidance of hypothermia, fluid management, and we need to have a plan of pain management. Okay. As far as anesthesia technique is concerned, there is no evidence to favor any one specific technique over the other. We can really choose any technique as far as anesthesia technique goes, but the aim should remain the same, and that is to minimize the impact of any anesthetic drugs on organ function and recovery. And the patient should awaken rapidly from anesthesia. Right. Also, for inhalational or TIVA, there is no evidence to favor any of the techniques as of now. Okay. Then, as far as possible, use shortest acting drugs, shortest acting agents, and muscle relaxant during the intraoperative period. All these guidelines are taken from colorectal surgeries and abdominal surgeries. That's why GA comes prominently here. Whenever possible, in all other surgeries, we can also use regional anesthesia. Also, during general anesthesia, we should monitor depth of anesthesia by some means. Okay. So if the depth is too high, what will happen is the patient will not awaken rapidly from the anesthesia effects. If the depth is too low, the patient will have awareness. So it is important to monitor the correct depth of anesthesia. Then the next question comes is how much oxygen to give. Initially, the thought was to give as high oxygen as possible so that it will affect the wound healing, etc. But some studies have shown some conflicting result. For example, proxy study, which was done in colorectal surgeries and abdominal surgeries. So they said that the short-term goals are good, the healing is good, and post-op recovery is good. But probably the long-term goals and long-term complications are more in high FiO2 group. So that's why the recommendation is to use the FiO2, which maintains the normal oxygen saturation. So if the patient saturation is good, even at 30% FiO2 or 40% FiO2, we should use that concentration of oxygen, and we should avoid very high oxygen concentrations for very prolonged times, right? Then about nitrous, of course, it is a very controversial topic, whether to use it or not. So concerns are what? The concern is it can increase incidence of nausea and vomiting. It can cause bowel distension. It can cause difficulty while operating for the surgeon. But the advantages are also there. The advantage is it can give excellent analgesia and pain relief. It can reduce the requirement of inhalational agent, and that is why it can fasten the recovery of the patient. So there are no studies which really demonstrate any harm or increased incidence of PONV, that is nausea and vomiting. So the recommendation is that we can use nitrous as long as there is no absolute contraindication. And probably we have to have caution and avoid nitrous in maybe neurosurgeries, any bowel obstruction cases, or if the surgeon has a clear difficulty while operating. As far as PONV is concerned, it is extremely important because patient is very uncomfortable if the patient has PONV after surgery, and it will delay everything. It will cause more ileus, it will cause pain, and it will delay ambulation, recovery, everything. So in spite of all the measures, still the PONV incidence is high, which is 20 to 30%. And there are certain risk factors which we need to see before surgery. So there are 4 main factors: female gender, history of motion sickness, non-smoking status, and use of opioids perioperatively. Right. So if there are 1 or 2 risk factors to the patients, we should cover the patient with 2 antiemetics. And the commonest agents which are used are dexamethasone and ondansetron. But if the patient has 3 or more risk factors, or if the patient is very elderly, then we need to have 1 more additional antiemetic, and probably we need to switch to TIVA with propofol rather than inhalational anesthesia. Also, there are many other factors which will affect PONV, like whether the patient is well hydrated before surgery or not, whether the oxygen saturation is good or not, temperature is okay or not, whether the patient was too anxious before surgery or not. So we need to alleviate all these factors as well for prevention of PONV. Then comes pain relief. So of course, pain relief will be the mainstay because it is going to affect your post-operative period recovery. And the recommendation is for multimodal analgesia rather than, one specific type of pain management plan for each patient. And it needs to be tailored according to the type of surgery, according to the type of patient, right? So epidural analgesia, which is the commonest gold standard for major abdominal surgeries. There are other blocks, paravertebral blocks, facial plane blocks. For other limb surgeries, you can really use regional blocks as well. There can be local wound infiltration, and of course, opioids, short-acting opioids. There are many other drugs like lignocaine, alpha blockers, magnesium, gabapentin, pregabalin, which are used, but there is no strong evidence for that as of now. So epidural analgesia, as I said, it is the gold standard as of now. What are the advantages? It provides very good analgesia. It causes faster mobilization. It reduces the length of stay, and it reduces the stress response, catecholamine release after surgery. But it is not without harms. It can cause disastrous neurological complications. And although there is reduction in length of stay, there is no significant difference in the mortality. There is no mortality benefit which is found in any of the studies. And especially now we have availability of other options like facial plane blocks, like quadratus lumborum block, or erector spinae block, tab blocks, etc., which provide equivalent analgesia in many of the surgeries. So we really need to see the benefit and risk of putting epidural or avoiding epidural. For example, now in knee replacement surgeries, epidural analgesia is hardly used, I guess, but more and more adductor canal blocks or femoral blocks are being used instead of epidural, right? So we need to see the risk and benefit before giving epidural analgesia. Epidural is still strongly recommended for abdominal surgeries, open abdominal surgeries, and thoracic, and all other surgeries, probably we can choose other modalities also. Fluid management, again, it is a controversial topic. Underhydration can cause problems, overhydration can cause problems, but the gist of the topic is that we need to give goal-directed fluids, individually tailored fluids, and probably cardiac output monitoring for high-risk surgeries. And balanced crystalloids are recommended rather than normal saline or any other colloids. Post-operative period, the most important factor again will be pain management and management of fluids. And other controversial areas, as I said, whether to use TIVA, whether to use inhalationals, whether to give carbohydrate loading for all, whether to use epidural or not, and whether we are auditing our ERAS programs regularly or not. So these are the topics where we still need to study and research. And these are my references which I have used. Thank you very much.
Thank you, Dr. Sukhda, for this very detailed and a very impressive explanation of a role of an anesthesia in the fast track surgery, how it can be used, various things can be used to help for the enhanced recovery after surgery. I think we can discuss also in our panel discussion what we have left actually to discuss. Now I would like to invite Dr. Amandeep Arora. Dr. Amandeep Arora is an assistant professor in urology in Tata Memorial Hospital, and he is a very dynamic and very passionate surgeon. And he is a very nice, communicable skills for the patient. His counseling way is excellent. And as a surgeon, how to affect fast track surgery, either the fast track surgery or tracking the safety during surgery. He will going to explore this aspect for the fast track surgery. So Dr. Amandeep Arora, please, over to you.
Yes, sir. Thanks, sir. Thank you so much for those kind words. Without wasting any time, today I've been asked to discuss about the surgical aspects of enhanced recovery after surgery. So the surgical aspects are basically something preoperative. It's not only about intraoperative. The job begins in the preoperative stage. So we have preoperative aspects which we'll discuss one by one. We have some intraoperative aspects which we'll also discuss, and finally the postoperative aspects till the patient goes home. So for preoperative, this is something that Sukhda doctor also touched on. What I would just want to say is, you as a surgeon are the first point of contact for the patient in the OPD, where you inform the patient that he or she has cancer. That itself is a big shock to the patient and the family. And the most important thing right there is to, behave like another family member to the patient and give some time, give them privacy, speak to the patient and the family in a closed room and be empathetic to them. You explain to them about their disease stage and the prognosis. Don't give them any false assurances, but also don't scare them. And speak to them about some specific issues like stoma and neobladder. This, in fact, is the only aspect of ERAS which actually prepares the patient mentally for what is going to happen with him. All other aspects actually deal with physical improvement of the body. The other preoperative factor is about bowel preparation. So the traditional teaching was that we do bowel preparation for small bowel surgeries as well as large bowel surgeries. But it has been found that no bowel prep also leads to no detrimental effects for the patient. Most of this data comes from colorectal studies, but we also have data from urological studies as well. Some centers still tend to use bowel preparation when they plan some major reconstructions like a neobladder. And also the GI people use bowel preparation when they are basically using or operating on the left colon. The next aspect to consider is the thromboembolic prophylaxis. So all our cancer patients are at high risk for thromboembolism because they are cancer patients. You add to that pelvic location for bladder, prostate, and colorectal. You add to that the long surgical time, and this just compounds the risk for having a venous thromboembolism for our patients. So our prophylaxis can either be pharmacological or mechanical. Ideally, it should be a combination of both. So we give the first dose of low molecular weight heparin 12 hours prior, that is on the night prior to the induction. And if you've had a late admission or for other logistical reasons, if that 12-hour window is breached, then we would want to use heparin because it has a shorter half-life compared to low molecular weight heparin. This does not end only during intraoperative period. Most of us tend to stop the anticoagulation once the patient is discharged, but the recommendations are that for such high-risk patients, you continue the extended prophylaxis for at least 28 days. Coming to antibiotic prophylaxis, so basically all the data about ERAS in urology at least is basically concerning cystectomy because that is our most major operation. So the antimicrobial agents in cystectomy as well as in colorectal surgeries should be effective against both aerobes and anaerobics. And cystectomy is a clean contaminated surgery, and a single dose of antibiotic is the actual recommendation for antibiotic prophylaxis. But we in our centers usually tend to give a lot more. We in fact give antibiotics for more than 1 day, more than 3 days in fact. There is not a lot of Indian data available on this. Coming to the intraoperative aspects, we would want to do minimal access surgery whenever possible and feasible. It is as oncological equivalent as open surgery, and it has its own benefits like less blood loss, less post-op pain, less bowel handling, and so less ileus. And all these finally together translate to a shorter hospital stay. So there is a definite proven benefit in some pelvic surgeries, but in some surgeries like cystectomy, the benefit is not actually proven in trials. This is one aspect of ERAS which facilitates other aspects because you're leading to a faster recovery to the patient and a earlier discharge. Early removal of the nasogastric tube. So traditionally we would keep the RT in situ till the patient has passed flatus and the abdomen is settled. But the ERAS concept is that we avoid an RT if possible. And if we have inserted the RT, we will remove it probably very soon, probably at the next post-op day only. High volume centers usually tend to remove these earlier, the nasogastric tube. About drains, so we would not want to put drains unless absolutely necessary. So in surgeries like radical nephrectomy, we will not put a drain. So you can avoid putting drains when you have done an extirpative surgery. But whenever you've done a reconstructive surgery, you would want to put in a drain, but then you would want to remove them as early as possible. Don't wait, till the output has fallen to bare minimum. Post-operative, you would want to mobilize your patient as soon as possible because prolonged bed rest can lead to a lot of issues. So you need to motivate the patient, manage pain. All this has been shown to reduce the length of hospital stay and also reduce ILS. And we need to encourage our patients to start walking and get out of bed directly from the first post-op day. Preventing post-operative ILS is the next aspect. So the surgery itself, the bowel handling during surgery, the opioids that we are giving for pain, all this leads to post-operative ILS, an impaired gastrointestinal absorptive function. ILS is defined as the inability to tolerate solid food by post-op day 5. So that is when you're thinking that your patient is actually in ILS and not recovering well. So this can be prevented by some elements, like you give epidural, you optimize the fluid therapy, you use minimal access surgery, you remove your nasogastric tube sooner. And some other measures are that you use chewing gum in the post-operative period. And this is one drug which can be used, which is called as albumopan. It's basically a stimulant for bowel motility, but this drug is unfortunately not available with us. And hence in the post-operative period, all that we are actually using is the chewing gum and some other motility agents. One last aspect is about early feeding. So traditionally, we would allow food only, once the patient has passed flatus, the bowel has settled, abdomen has settled. But the ERA's concept is that the early feeding is in fact safe, and it in fact promotes bowel recovery, and you help to shorten hospital stay. So there is a trend towards a lower incidence of all surgical-related complications if you have started early enteral feeding. To summarize, our surgical aspects for the surgeon, they work hand in hand with the pre-op and the post-op aspects, in fact. And some factors may potentiate other factors. And not all factors may always be applicable or possible for you, and hence we need to choose wisely. Our final aim is to reduce the hospital stay for patients as short as possible, to keep it as short as possible, to reduce the physical, mental, economical, and financial stress for the patient, as well as the family.
Thank you, Dr. Amandeep, for enlightening us for the surgeon's perspective towards the safety during surgery. And it is not during, it is the either is it also pre-operatively and intraoperatively and post-operatively.
Yes.
So if we describe, the surgeon is the most important person in this whole management, because from the day one when he sees the patient, he or she sees the patient until the discharge, he's the person who in maximum contact with the patient throughout the journey from admission to the discharge. And in between there is a very much good role or important role of anesthesia from pre-operative to intraoperative and the post-operative thing. And again, now the role of physiotherapy. So I generally describe physiotherapy is the most one of the other most important aspect, because it is the rule when the patient on day 1 comes out of the bed and day 2 out of the ward, and as soon as possible out of the hospital. The physiotherapist generally they help the patient to move from the bed to out of the hospital as soon as possible, along with the other modalities as a multidisciplinary approach. So now I would like to welcome Dr. Sarika Mahajan, who is a senior physiotherapist in our hospital, and as a routine in every our joint clinic, she or her team member comes to our joint clinic session, and please give us some knowledge about the importance of physiotherapy as far as the faster surgery is concerned. Sarika Mahajan, it over to you.
Yeah, thank you so much for your kind introduction. Since everybody has spoken so much about what happens to the patients post-operatively and how we prepare them, now let's see what our role is. And this is a very good title given to us, that we do a lot, but it is really minimally explored. And there are different phases to physiotherapy. So I will first begin with the pre-ops part, which is also known as the prehabilitation or cancer prehabilitation. It's a process of care which actually starts from the time of diagnosis and between the time of diagnosis and the actual treatment begins. So what it actually says is that it includes the physical and psychological assessment, which needs to be done at the baseline to give us an idea about what the patient has impairments in which domains, so that we can provide them with appropriate care. Also, we are actually preparing the patient to get physically and mentally well, so that they will be able to take all the treatments and whatever treatment side effects they are going to face uh, appropriately. Along with that, there are many other studies which have been done now, which talked about how a unimodal or a multimodal prehabilitation program is actually going to reduce morbidity in the patient and also improve the patient's physical and psychological health. So when I'm talking about prehabilitation, it doesn't mean there is only one domain. As I said previously, there are multiple factors, but we are going to talk about what the physical function is and how what assessments we need to do and how interventions are going to benefit them in the ERAS journey. Okay, so first we are going to do a cardiopulmonary status examination, which Dr. Sukhda also highlighted. So subjective assessments are very easier to be done, and most of the physicians and therapists do it in their routine practice. So first, the basic question which we usually ask the patient is, what is their effort tolerance? To find out their effort tolerance, how many number of stairs they climb. So higher the number of stairs, better the fitness is. Also, the next thing which we can use is the Vogue scale, which actually tells us about the rate of perceived exertion. So this is basically an objective assessment, but can be routinely given to the patient to identify the level of dyspnea they have, or they have any breathlessness. The most simplest of the test is the talk test, which also is very easy to administer. That is when a person is running and is able to sing a song. That means the patient is at the highest level of his fitness. Otherwise, the patient, if you see, in our setup, when the patient is walking, the patient is breathless. So that means the patient has a very poor functional status and they need some kind of intervention. The other tests which can be used are the objective methods. Mostly the pulmonary function test, which gives us an idea about the restrictive or the obstructive lung diseases, and CPIT, which already spoken about. The easiest one and the simplest one is the 6-minute walk test, which can be done in a routine setup, and it actually gives you an idea as to what is the status of the patient, and based on the 6-minute walk test, we can actually plan an aerobic workout program for the patient, which can be done on supervision, and also they can be given as a home program. Okay, so when we done the assessment, so we have to not only look at the cardiovascular status, we also need to look at the muscular status. So there is something called as Omni scale. Because there was a constraint of time, I have not put any slides of it. So Omni scale is a very easier scale through which we can assess the strength of the patient. So once we've identified what is the fitness of the patient, we are going to specifically design the exercise protocol for them. Okay, so once the exercise is given to them, we also need after every 3 weeks, so that we can always increase their exercise intensity and duration, so that we have a progression in their exercise program. Also remember, the most important thing is giving rest, because recovery is also equally important when an exercise program is given. So how do we build up this program? We are going to first start with a warm-up and a cool-down program, which is going to be of around 5 to 10 minutes, which can be any mobility of the upper limb, of the lower limb, spot marching, jogging, light jogs, and walking. A small walks in the room also can be incorporated in the warm-up and the cool-down session. This is basically to build up your body for the main program. So main is your conditioning phase, which is going to be should be at least for around 20 to 60 minutes, and it should include your aerobic and resistance program. Okay, and also we should have a flexibility exercise program, which should be in between the warm up and cool down, and should be for around 10 minutes. Okay, so according to the FIT principle, that is frequency, intensity, time, and type, which is recommended for cancer patient by the American College of Sports Medicine, it says that the exercise program should have aerobic and resistance exercises. The aerobic exercises should be done 2 to 5 times a week at an intensity of around 60 to 80% of their HR max, which can be calculated based on their age and age, or the 6-minute walk test. Also, they can use a RP scale, that is to find out the dyspnea, and on that basis also the patient can be prescribed exercises. So what is the exercise time should be? It should be around 30 minutes. So if you're doing it for 5 days, it becomes around 150 minutes. The whole idea is that the person should be able to do moderate intensity for 150 minutes per week, or around 75 minutes of exercises at a higher intensity or vigorous intensity. So if the patient is coming to us, then we usually use the cycle, or we can do a treadmill for this aerobic training. If the patient is doing at home, then we can give them a home program as to what speed and what speed they're supposed to walk. Okay. For resistance training, we are usually advising them to do 2 to 3 times a week, and we use the Omni scale, as I said before. And this exercise has to be repeated 8 to 10 times, and the set can be started at 1 set and can be progressed to 2 sets. Okay, so these exercises can be done with help of TheraBands or weights, or if the patient doesn't have any of such access, they can also use body weights as in doing free exercises. Okay, but here in Tata Hospital, what we do is we start with giving a pulmonary rehabilitation session, wherein we give the importance of what are the exercises we are supposed to do, how they are going to benefit us, and what are the surgical assaults which are going to happen, and how we're supposed to prevent them. Not prevent them as in how do we support them in order to better do their breathing, and also to have a effective coughing techniques. Also, if the patient has any secretions, how we are supposed to clear them, that also is advised to the patient. And if the patient has excessive cough and secretions, then we also provide them with postural drainage. And if the patient has any weaknesses or their capacity is extremely low, then we call them for supervised exercise session. Okay. So I'm sorry, this slide is repeated. Okay. So there are benefits to pulmonary rehabilitation, as mentioned by the ATS. It says that it has shows to improve the functional capacity, it reduces dyspnea, it also improves the quality of life and reduces the need for hospitalization. So what are the barriers to exercise in cancer patient? Poor general condition, and if the patient is very, very debilitated, if the counts are extremely low, and if they have any pre-existing infections. Also, there are other factors which you should consider, like fatigue, and if they're undergoing any chemotherapy, because of which they have undue weakness. So what are the contraindications when you're prescribing these exercises? The patient has nausea, vomiting, and fever, and the patient is very weak, fatigue, we are not supposed to give them any exercises. Okay, so this is a systematic review which actually looked at physical exercises and breathing exercises, how it helped in improving the overall complications and postoperative pulmonary complication, reducing pneumonia. So they also recommend that the patient needs to be assessed, a baseline assessment needs to be done, and based on that, a patient should be given a home program which should include around 20 minutes of exercise at home, which should have a warm up and cool down period, and this should be done. Patient should be advised to do these exercise at least 3 times a week, and to monitor these, we should provide them with a patient compliance diary through which we can observe them. And now there are many devices which can be used, like a Fitbit band or accelerometers. Okay, so this was what we did in a preoperative session. Why do we need to do in a preoperative or pre-treatment beginning session? Is we want to improve their strength, not only the muscular and the aerobic strength, to face the post-operative period. So once the patient is operated, we see them bedside in the ICU, and we start with the breathing exercise. As you can see here, the therapist here is making them do the breathing exercises. We start with inspiratory and expiratory muscle exercises, for which we can use these different devices. This is a flutter, this is a acapella, the spirometer, which I'm sure everybody knows. This is a balloon bladder. So these are the exercises which are already told to the patient or advised during the preoperative period, and then they're better compliant to do it in the postoperative period. Also, if the patient has any retained secretions, that can be removed or cleared through various physiotherapy maneuvers. And also we have something called as a vibrometer, and encourage the patient to do huffing and coughing. Now we know that prolonged bed rest can cause a lot of respiratory and musculoskeletal changes. To avoid that, in DMH, we start with active and passive movement, that is joint mobility exercises in the ICU itself, or at bedside if the patient is shifted out. And we get the patient onto the chair, Then after monitoring all their vitals and the saturation, we start with ambulation. Before proceeding to that, we have to do all these things. We start with spot marching and then make the patient walk with support and without support. Next, before we, there are many evidences for why we need to start with early postoperative mobilization and what are the things which you need to consider. So first is motivate the patient to do or be part of the mobilization. Adequate pain relief should be given and prevent any orthostatic intolerance. Again, there are various guidelines for how and when the patient should be mobilized, but this is a paper which actually talked about the guidelines of ambulation, which says that post-op day one, we are supposed to get the patient out of bed for at least 6 hours and make them walk for at least 10 to 20 meters. On the next post-op day, we have to make them walk at least 100 meters. And for after 3 days, the patient should walk more than 100 meters. And what are the benefits of doing these exercises? So when we get the patient outside the bed early, there is chances of reduction in chest complication. There is counteracting insulin resistance. Then it is also going to reduce the pain and decrease the chances of developing ILS. And it is going to help in recovering faster.
Thank you, Dr. Sarika, for this detailed explanation of role of physiotherapy. So I would like to say physiotherapy is again a one pillar where the foundation of the fast track surgery is made, and we will discuss the practical aspect in the panel discussion, right?
Okay.
And now I will like to invite Dr. Shiv Shankar. He is a chief dietitian of our hospital, and really I wonder that how he can manage all the diet chart of all the patient in TMS, because in cancer, after the cancer surgery, almost I would just say 90% of the patient we refer for the dietitian for the diet management. And how, let us see how he does this wonderful job by calculation and whatever the logics he applied to assist to have a fast track surgery in the surgical patients. Dr. Shiva, up to you, please.
Yeah, thank you for those kind words, Dr. Mahendra. And without wasting time, I would like to go to the agenda. Nutrition management in perioperative, or maybe the ERAS protocol, what we may call it as. So we all know why nutrition is important. Just to keep an flow of the talk, I would say that we need to understand that malnutrition is mostly is under-recognized or under-treated, and people are refusing to accept it as a disease or a comorbidity. So it is where the challenges lie over there. And we are really thankful that 2016, the perioperative surgical guidelines which came into and really sensitized the importance of the nutrition among all the surgical aspects. And of course, the ERAS protocol was also available in just 1 or 2 years before, and that just emphasized the need of the nutrition during this phase. And the data do suggest that the well-nourished patients usually tolerate major surgeries better than the malnourished ones. And when it comes to the cancer, malnutrition is the cause, which is just even the disease as well as the treatment are the consequences of the malnutrition. Perioperative nutrition, why again it is more important, the protein deficit. We are predominantly, the Indian population we eat very less protein, and that results in slow healing or slow return of the bowel functions, and there's a greater number of infections. And of course, the malnutrition is associated with high incidence of post-operative complications and death as well. We have our own challenges, as I said, the refusal of the treating doctors to recognize as malnutrition as one has some kind of an impact in the outcome of the treatment. Fortunately, in TMH, we have a totally different kind of a scenario. We are really fortunate to have the oncologist supporting us and giving a free hand to really go about the way the nutrition has to be practiced. But it is not the same in other hospitals. When we meet the other hospital dietitians, they have a lot of challenges over there. And we also see that the patients are referred to the dietitian just 1 or 2 days before the surgery, which is actually impossible for any patient to build up for the surgery. We need at least 7 to 10 days, and even the guidelines do say that at least 14 days are required to build up the any kind of a patient for a surgery, specifically those who are undernourished or are at risk of malnourished. So there we need to be more sensitive for this. role of inflammation, which is very less spoken about in the field of nutrition. It was never being spoken about into the classrooms or the colleges where the syllabuses are being taught to the nutrition experts. But of late, in the last 2-3 years, we are the ones we started talking about the inflammation, and then the relation to the nutrition. How inflammatory nutrients can be removed out from the dietary aspects, and how anti-inflammatory nutrients can be incorporated for the betterment of the patient's outcome as well. So then you have, when we come across these Euro patients, the other challenges are like they are more or less of advanced age. They are more of above 45-50 years or maybe more than that, and they have a normally prolonged hospital stay as well. The frequency of post-operative complications are high among these populations. And inflammation, as I did mention about, it is the inflammation which causes the malnutrition. Earlier, we used to think that the malnutrition which causes the inflammation, which is the other way around which it goes about. So if you want to address the malnutrition aggressively, we need to address the inflammation and not the malnutrition, because the cause is more important rather than what we see patient losing weight or not able to eat food properly. Those are just the symptoms. What is causing is the inflammation. Yeah, if you can control the inflammation, you can contribute through the diet, try to minimize the inflammation and see the symptoms can be improved. And we have various studies being, speaking about the nutritional interventions, and they can be predictive parameters as well for the outcome of the treatment. Even the death also can be predicted. Like the HGAC patients may not survive more than 90 days post surgery as well. Of course, the studies do talk about various other sites as well. I'm just not talking about the Euro over here. So it has, but very less studies have been conducted in urology when it comes to the nutritional aspects. Little bit of understanding regarding when it comes to the nutrition and what we need to look upon and what are the other challenges over here. The first thing is the catabolism, what we come across with these patients. And whenever there is a patient who is losing this weight and is not able to control the weight loss, and anorexia set in and is not able to have his meals adequately, the body is going to utilize the energy resources, that is specifically the muscles over here, which are broken down, and the amino acids being released are the glutamine and alanine, which are branched chain amino acids, which are through the circulation goes to the liver, and the liver thinks that these are the fuels to produce glucose and acute phase proteins. These are the futile usage of the very expensive kind of amino acids. Amino acids are very expensive because I say the protein itself, the food protein itself is an expensive thing, and body doesn't store amino acids. If you see the carbohydrates and fats, even if the patient is lying on the bed, not even doing any activities, still the carbs and the fats get deposited. But the protein to get deposited, the patient has to be very active, has to be mobile, as Dr. Sarika did mention about the physical activities, why it is important. And if the physical activity is not there, even if I'm feeding around 1.2 to 1.5 grams of protein, it is not going to be absorbed in the body and it is not going to be stored. So physical activity has to complement with a good amount of protein supplementation over here. And when the patient is losing these branch chain amino acids, we have two categories of amino acids. One is branch chain amino acids, the other one is aromatic amino acids. The branch chain amino acids are further expensive, I would say, and we should not be losing the branch chain amino acids. This is the last thing what anyone would like to have taking a risk of if you're still losing the muscles. Doesn't matter. Muscles are the best kind of a buffer which helps a patient to survive through the process of the surgery, and thereafter the recovery and the rehabilitation and then the survivorship. So we always say the patients to even if they have a good weight, the weight is not actually the indicator of the body composition. The body composition should reflect upon the muscle mass and the fat mass, how much they are carrying. So yes, BI is one of the equipment which is available as of now, latest technology, where we can measure the muscle mass and the fat mass over there, and we can advise the patients accordingly. If the patient is carrying a lot of fat mass, the fat needs to be reduced, and if the patient is having a less muscle mass, the patient can be advised for better protein utilization and better physical activities or exercise to build the muscle mass. Over here, the catabolism, I did speak about the proteins are very expensive and very rare, and the patients who are losing weight is a very huge challenge. We know that the patients undergoing the surgery, for whom it is the greatest thing for the recovery, what we actually look out for surgically, and we need fibrinogen for that one. And it is just a very simple calculation what the studies do put it across over here. You can just see this calculation. The body to produce 1 gram of fibrinogen, if the patient is not fed, maybe 1 or 2 days, 3 days, 4 days, however the number of days if he is not fed, the body is going to utilize the muscle protein. How much of the muscle protein to produce one fibrinogen is 2.6 grams of muscle protein is being utilized. Now, muscle protein, when it is being utilized, how much the actual muscle is being lost by the patient is 10 grams. Now, you may say it is a very minuscule, doesn't matter. Even if he is losing 100 grams, I don't mind. Anyone who would say into that kind of a thing. But when you come to the third row and the fourth row, when you see if the body's requirement is say around 100 grams of fibrinogen, the muscle protein what the patient is going to lose is 260 grams. That is approximately comes to 1 kg of the entire muscle mass. And in case if the patient has undergone a major surgery, the fibrinogen requirement is 1000 grams. And you can just see how much the muscle protein is being lost, 2600 grams, which happens to be almost 10 kgs. Now, as I say, 10 kgs may not be losing at one day or something, but the 1 kg loss, what I would like to bring it to your notice over here. In the end, I have a live case which is going to be talking about it. How a healthy person also can lose 1 kg of muscle mass each day if he or she is not fed adequately. Over a period of cumulatively, if you see the 10 days or maybe 2 weeks that the patient is not fed adequately and the protein requirement is really very high, then I can say the last row happens to be a very dangerous kind of a thing where a 10 kg of muscle mass is being lost. When we want to build up 1 kg of muscle mass, it's very huge challenge. And losing 10 kg over a period of even 2 weeks or 3 weeks, it is something like you're losing a lot of money over a period of just not benefiting anything, and you're spending your money on something which is not going to be fruitful. Then comes the hyperglycemia. This is one of the other things which we will be concerned of. So what happens in the catabolic patients is there's a wrong message which is being sent to the brain, and when the cytokines are being released, and these cytokines are going to infuse a lot of misadventures. That is the breaking of the muscle mass, breaking of the fat tissues, and both the muscle mass and the fat tissues are being converted through gluconeogenesis. Glucose is being produced. If the patient is still eating some kind of endogenous carbohydrates, there will be a lot of glucose being produced over there. And when there is an excess of glucose being produced, there is an insulin resistance. That is why if you see in our own data, we have seen that non-diabetic patients, we have seen that 27% of the patients were hyperglycemic. So it shows that almost around 30% of the patients who are non-diabetic, I'm saying, are always hyperglycemic. So this is a very concerned area. And the glucose monitoring and management is a huge challenge with these patients. And this is one of the area where a nutritionist has to keep an eye on this one, how the blood glucose can be really maintained from the beginning, from the day one, I would say. So that is where the challenges lie out. So dietary intervention becomes very important for these patients' rehabilitation when the patients come with the increased blood sugars as well. I did mention about the protein, very expensive and very much required. And any patient undergoing the surgery, for home healing, something around 1.2 to 1.5 grams of protein is required. Normally, we Indians, what we eat is 0.6 to 0.7 or maybe 0.8 grams of protein per day. This is what we normally consume. Even if you are non-vegetarian, eating 3 times a week, still you will be consuming around just 0.8 or 0.9 grams of protein. Very rarely you'll come across any Indian eating 1 gram of protein per day. So now when the recommendations are so high, around 1.2 to 1.5 grams of protein, that is literally 50% more than what normally we consume when we are healthy. So meeting this requirement for a dietitian and seeing that the patient is compliant to the requirement, there's a huge gap over there. The patient has anorexia, delayed gastric emptying, and other complications. A lot of symptoms he comes with, and we want to push upon, pump around 1.2 to 1.5 grams of protein. There's always a gap to be seen over there. And this is where the protein requirement, how supplementation can be done is a very huge challenge. However, when I say that this protein I'm talking about, all the micronutrients are also important. All protein supplements are not the same. Every protein supplementation has a different kind of a composition, and every clinical condition demands to be a specific kind of a composition to be used. This is where again we all go wrong in randomly recommending any kind of a protein. Oh, this has a 30 or 40 grams of protein. It's better that I recommend this one. Or maybe a whey protein, the one who is using in a gym, which has a 70 to 80 grams of protein. I have seen good doctors around. I keep on going to many places in India. They recommend such kind of a proteins which are actually not the right kind of a protein supplementation to be given into a clinical condition. A clinical condition demands a lot of introspection into the assessment. What kind of symptoms, what kind of condition, what kind of treatment, and what is the goal of us? Is it the inflammation I'm concerned about? Is it the wound healing I'm concerned about? Is it the prehabilitation? Is it the rehabilitation, survivorship? Everything does matter. Not only that, if the patient is having a Kyle's leak, if the patient is having uncontrolled sugars, if the patient is having obese, or underweight, all these things matter into the selection of the protein supplementation. Further, the components of what we normally see to the patients, whether the patient is allergic to any kind of food items, and there is a lot of myths when the cancer patients come to you. They hear a lot of things, they read a lot of on the social medias and come with a lot of their own perceptions about the diet. They have intolerances. If you see most of the Bengali patients, they are intolerant to the milk and milk products, so they don't want milk to be recommended to them. And adequacy, how much is adequacy is really can be justified. That again depends upon the patients, what weight the patient is carrying, what weight the patient had around 6 months back, and what is the desired weight in the next 3 to 4 months, what I need to achieve. So these are the trends what we also look into the aspects. Patients undergoing any kind of a surgery, this is one PON score. There's a pre-operative nutrition score what has been recommended by the SPN guidelines. So this can be utilized. But if you're going to send all the patients to the dietitians, we don't want a PON score over there, because in any way, all the patients have been referred to the dietitians. The screening is not at all required. Where screening is required, where the patient can be filtered out, and not all the patients to be sent to the nutrition clinic, this PON score can be used, and there the patients can be filtered out. When we want to build up the patients, yes, the first thing is like you would like to counsel the patient and see whether the patient can adequately consume, which is normally 70 to 80% it is not possible, because they already have a lot of symptoms I did mention about, either due to the diseases or due to the treatment itself. When the counseling is inadequate, we try to supplement through the ONS. If ONS supplementation is not adequate, then we go for the enteral nutrition, and for the last attempt is the total parental nutrition. This is a guideline what I was talking about. Preoperative fasting, Dr. Subhadra did mention about. I don't want to really elaborate on that one. Yes, we all know that it is being totally out of the practice now, and yes, the fasting and fed state, they both have clear defined benefits and drawbacks. And as you can see on the screen, if the patient is being fasting, maybe the glucose and insulin may be normal, but in a fed state, it can be increased. But what is more important, when you are feeding a patient, even some amount of carbohydrate is being given just before the surgery, the patient is into an anabolic phase, not into a catabolic phase. Patient undergoing a surgery into anabolic phase has a really immediate outcome even after the day one of the surgery, and thereafter, the recovery can be faster, and the post-operative complications can be taken care as well. Of course, not all the complications, but it can be definitely minimized. What kind of a carbohydrate is actually recommended? We did hear
Dr. Shiva,
Dr. Subhadra did mention about, yes. The maltodextrin was recommended, but whatever the feeds we use, like what has been mentioned earlier, they have the osmolarity of something around 7 to 800. So they are not actually recommended. And these are some of the international carbohydrates what they are using. Immunonutrition is recommended just 3 to 4 days or maybe 7 days before the surgery and 7 days after the surgery. Feeding can be started within 24 hours. There is no point of holding the feeds just to see that the bowel movements are being seen. And yes, earlier it was seen that we should not be giving any fluids over there, but these are being taken care. Even if we are not putting the body is producing around 6 liters of fluids over there. Clear liquids are not the real kind of a diets which are actually not required. This is a case which I was talking about. He is a nutritionist and a very well-known doctor as well, and he has lost 20 kgs in over a period of 20 days. So you can just imagine this can happen to a nutritionist who is himself is a doctor and who lost the muscle mass, as did mention, about 1 kg per day. And thank you. All these take-home messages have already been spoken by others as well, and maybe during the discussion I will take it further. Thank you so much.
Thank you, Dr. Ashiv Shankar, for in-depth knowledge in this unknown subject for surgeons. Actually, we just see the macro level things, and you are dealing at the micro level in the body. So definitely your role is very important. Unfortunately, it's not in the picture with the patient because you are doing work behind the scene, but it is very important. Thank you.
I thank Dr. Shiv Shankar for the great message that has been given, and other panel members for their presentations. Now I welcome Dr. Mahendra Pal to take over the stage for the panel discussion on the case, and we will try to keep it short and try to have more discussions going forward.
Yeah.
Sir, please, over to you, sir.
Yeah, so I'm just sharing my screen. Thank you, Dr. Naga. And I will just request my panelists to be short and crisp in the answering. Already, you have thrown a very in-depth knowledge about all the aspects. We just want to discuss the practical aspect of this topic, fast track surgery, planning and clinical application. So we would like to discuss only about the practical aspect. So this is the case summary. The patient is a 69-year male. He is a company executive, smoker, 10 cigarettes a day for at least 10 years, occasional alcoholic, and active lifestyle, daily walking of 5 kilometers. And he had a history of diabetes, hypertension for at least 10 years and bypass 5 years back. He has good apple tolerance and can climb 4 to 5 floors without dyspnea. He had right side abdominal pain with no hematuria, anorexia present, weight loss something of 6 kg in a 1 month, and there was a sonography, the 8.8 lump pulping in the right lumbar region. Hemoglobin 14.8, WBC count normal, platelets normal. It is in lakhs, sorry, my mistake, in lakhs. Creatinine is 1.7, albumin 3.9, alkaline phosphatase 114. So CT scan was done, which shows 7 to 8 centimeter mass, right single artery, and there is a tumor thrombus into the retrohepatic with suspicious IVC wall involvement. And MRI suggests IVC wall involvement at the right renal vein and the IVC junction. No dolor distance mets, and left kidney is normal. This is the imaging. If you can see this mass, right side mass, the contrast enhancing mass is the IVC thrombus. If you can see some bright circular area in the second picture. The bigger one is the IVC and the with thrombus. And here is the thrombus is going up to the intrapediabetic part. So, Dr. Aman, so we want to the pre-operative as we discussed. What things to be considered during the initial assessment in this patient?
Right, sir. So we've noted that the patient has multiple comorbid illnesses. So I would want to have them evaluated by my anesthetist when the pre-anesthetic assessment is done. Secondly, I would want to inform the anesthetist that it's a supramajor surgery. We'll be taking control of the cava, opening the cava. I'm anticipating blood loss. So all those things. So I intimate to the anesthetist that we are anticipating a high-risk surgery, longer duration of surgery, more blood loss, so that all these points are taken into account when the anesthesia assessment is done, so that we have things ready for our backup. I would also, because it's a high-risk surgery, patient is going to be in some pain because we are going to have a big incision. I would want to involve the physiotherapist, ask the patient to start chest physiotherapy exercises right away, so that because these are difficult to teach them in the post-operative period. And definitely, with the large incision and with the morbidity with the surgery, the patient needs to be nutritionally optimized. I noticed that the albumin is fair enough for this patient at 3.9, but some bit of nutritional optimization would also be good. The final thing was that the creat was a little borderline high, so we would want to evaluate that also. Yes, sir. I think Mahendra sir's connection is lost. Sir is back, I think.
Yeah, I think he's back.
Sir, you're muted, sir.
It was some network issue. Just
Yes, sir. Yes, sir.
Yeah. So just now my slides are visible now.
Yes, they are. Yes, they are visible, sir.
Okay. Sorry for the interruption.
Yes, sir.
So you were saying about the pain. You want to involve the physiotherapist, right?
Yes, sir. Physiotherapist, my nutritionist, my nephrologist, because his creatinine is borderline high.
Okay.
And yeah.
Anything more important as a part of this surgery towards fast track? Hello.
Hello.
Yeah.
Sir, I would want to. I would have a detailed discussion with the patient and the family about what we have found, what is the disease stage that we are dealing with, what is our plan of management, and what likely survival as well as post-operative recovery that we are aiming at.
1 minute. My total screen is gone. Just wait a minute.
We can see the screen actually.
No, but I cannot see my screen. I don't know.
Sir, you have to stop sharing and then
Yeah.
start again.
Yeah,
sir.
I'm sorry. Yeah, is it visible now?
Yes,
Yes,
sir.
sir.
Yes,
Now
sir.
it
We
is
can.
visible. Yeah.
Okay. So anything else you want to do other than these 4 parameters, which is the, again, one important aspect of the fast track surgery? And I think you mentioned in your presentation is the counseling of the patient and the relatives.
Yeah.
Right. So any special approach during the pre-anesthetic checkup for the fast track surgery, Dr. Sugda?
Yeah, so I think apart from the regular pre-anesthesia checkup that we routinely would do, this patient is elderly and has a cardiovascular risk, and the surgery is major, involving major blood loss, probably requiring cable control. So probably first and foremost, I think we need to have a joint discussion rather than just assessing it separately. Probably what we have in our hospital as a high risk, joint committee discussion, so that the surgeon is there, the physiotherapist is there, and the anesthetist is there, and we can discuss the pros and cons of each aspect. So probably that is something which is needed here.
Okay. So do you want to discuss at the before the surgery about the type of anesthesia surgery as a main determining factor which may act towards fast track surgery?
Yeah, so in this particular case, because it is going to involve cable control, probably, for thrombus removal, it is the general anesthesia probably is pertinent here. It cannot be done in regional anesthesia. So I think the plan of surgery will be general anesthesia, but with probably epidural analgesia, because the pain relief component will be very important. And as I said, the type of anesthesia per se will not determine how we deal with the agents, and the other aspects of pain management probably is more important rather than just choosing the type of anesthesia.
Okay, so any pre-operative scoring, as you mentioned in your presentation, would you like to do a specific scoring which can be focused towards fast track surgery?
Yeah, so this patient clearly has had a CABG surgery in past, so we need to assess the risk of perioperative cardiac dysfunction in this patient. So there is a risk calculator, which is Gupta's cardiac risk calculator or Lee's cardiac index. So there are 4 or 5 parameters which it really takes into consideration and assesses the percentage of risk in the postoperative periods in terms of percentages. So we can calculate that. Also, some objective parameter for functional capacity in terms of either a treadmill stress test or dobutamine stress test is required in this patient. And as a patient is a smoker, that cessation of smoking is absolutely important because it is going to affect our recovery in the postoperative period.
Yeah, so I would like to put in that way as Amar's main this thing, the aim was to have a fast track surgery, to have a safety during surgery. And I think these are the aspect, the patient factor, which anesthetists can see better for the fitness than the surgeons. Am I right, Aman?
Yes, definitely agree, sir. Yes.
Yeah, okay. So again, Dr. Sarika, role of physiotherapy in already physical active patient. So what is your take in this patient? Actually, he's a very active patient having some comorbidities and is going to have a very major surgery in uro-oncology.
Yes. So from the case, I can only say that, the patient is aerobically very fit, but he is not into any resistance training. So I think I would like to put him on do some resistance assessment and then do some strength training for him. Likewise, I would also like to work on improving his strength of the lungs, because the patient is already a COPD and post-operatively he is going to have impact on his lung capacity. So I think, getting him on an inspiratory muscle training is going to be much more beneficial because the patient is anyways active.
Okay, so how these parameters are going to help, like muscle strengthening, how going to affect the outcome as a fast track surgery?
Yeah, so there are many studies in which they have said that, muscle hypertrophy, which is done before the surgery, actually helps in patients recovering faster. because when you have a good strength of the muscle, specifically the core strength has to be very, very good in urology or abdominal surgeries. So core strength and the abdominal strength needs to be worked on before the surgery when we are going to intervene. So
Okay.
that is going to be beneficial. Yeah.
So you want to say again, if we prepare before the insult, then we
Yeah.
can repair the insult very well. Am I right?
Yeah. So patient will not have any long-term, what do you say, weakness or pain issues, which happens post-surgery. So in order to prevent that, we'll have to train specifically to the core.
Okay. So does the physiotherapies are specific for the surgery wise, or they are the common physiotherapy?
So it depends. If the patient is going for a thoracic surgery, then we know what are the incisions going to be like. If the patient has an abdominal surgery, we know what are the incisions going to be like. So if it is an abdominal surgery, it is important to work on strengthening the core muscles and also the abdominal muscles, which are going to be subjected to surgery. Okay. Secondly, when we're teaching these patients about these exercises also, it's important to tell them what happens post-operatively. That is, coughing gets affected because because of the abdominal incisions. So supporting them during the cough and training them to cough effectively from pre-operative period is also very effective and helpful post-operative.
Okay. So the bottom line is it is like a general measurement with the site-specific measurement. Both should be there for deciding the
Yes.
physiotherapy. Fine.
Yes,
Great.
absolutely.
Great. Now, Dr. Shiv, he is an executive. Nutritionally, he was very good, but now recently he lose weight of 5 kg in 1 month. So about the diet, as a dietitian, what should be a healthy diet, and how does it influence the surgical outcome in cancer patient, in non-cancer patient? As any difference, or both are same?
No, it's all the entire packages are different. Here I would say that even though he has lost weight, my focus will not be, to gain the weight in the short-term goals. So which cannot be done, which cannot be achieved. So my focus will be to see that his diabetes is being under control, and is physically active, and good amount of protein is being given, and maybe anti-inflammatory diet is being recommended to him. And maybe I would like to try this patient not to be on insulin dependent in the near future. If he's not as of now in the near future, but if he's already into the insulin, maybe I would like to see that the insulin doses can be reduced over there. So the causes, as we heard Dr. Sudha mentioning about the strict control of the sugars, have been shown to be detrimental rather than beneficial over there. The dietary control of sugars has been shown beneficial, but the controlling of sugars through insulin management is more harmful. So I would see that my patient can be on less insulin, or maybe patient may not be on insulin. So this is my personal goal over there. And regarding the weight gain, if he is underweight, maybe during the recovery, once the recovery phase gets over post surgery, during the survivorship, I would see that he achieves ideal body weight with good muscle mass and has a good physical activities, and he is seeing that the fat mass can be reduced, because if he is diabetic hypertensive, I assume that he will be overweight by this time. He already had a cardiovascular issues as well. If he has undergone some kind of a treatment, and maybe he has lost cardiac cachexia might be setting, and maybe further these complications. So it's a very hypothetical situation, whatever the limited information is available to me. But depending upon these informations, I would say I would be better ask the patient to manage his sugars to the best, and maybe recommend immunonutrition perioperatively and post-operatively for the first week and the next week post-operative. Thereafter, if at all any symptoms are there, we do more of symptom management.
Fine. So in blood parameters, would you like to see any particular parameters who will decide your diet management?
What I normally do is like,
hemoglobin?
the question is for me.
Yeah, for you.
Yeah, thanks. What I normally do is I don't actually target what kind of sugars I need to maintain it over there. But normally what I do is like whatever the sugar levels they have reported to me, my focus will be to reduce at least to 10 to 20% of the reported level. However, there are no kind of guidelines or no studies on this one. But I see even hyperglycemia is a inflammatory condition. So the more the inflammation, the more the patient is going to be having further complications. So if the albumin is really good. So again, albumin is not an indicator of nutrition, but it does indicate the inflammation as well. So here you have two contradictory conditions over there. Albumin is really good, and diabetes, I don't have the values of the HbA1c was not available. So maybe and he has lost weight. Assuming that this patient will be more stable, because any patient who after losing maybe around 10% of his present weight, even if it is diabetic, the sugars do come under control, or maybe at least they come down with the whatever the regular sugars were there, and maybe a reduced doses of medications and other things also maybe. So this is what I can say, a very hypothetical condition where the sugar management can be a focus over here, not the weight management, and maybe the prevention of the infection through immunonutrition perioperatively, I would focus it.
Okay, fine. Again, I'm not able to change my slides. Okay.
Sir, shall I share? Okay.
So, pre-operative management, fitness, nutrition, physiotherapy, I think this we have discussed. So, fitness, Sukta already discussed. Nutrition, Dr. Shiva already told. Physiotherapy, we discussed about that. So, Dr. Aman, surgical planning, pre-operative period. So, do you want to do some homework for the pre-operative planning?
Right, sir. So after the patient has physically been optimized for surgery, we would want to sit as a team and review the scans and plan out the actual intraoperative workup. And we would have taken opinions about the thromboprophylaxis. This patient has a very large tumor. He might also be having hematuria. And so I would want, if he does have hematuria, I would want to speak to the thrombosis clinic, if you know, how do we go about managing his thromboembolic prophylaxis. The other thing is, because the tumor is very vascular, might want to consider angioembolizing the tumor 1 day prior or maybe 48 hours prior, so that our surgical duration reduces, blood loss reduces, basically the intensity of the surgery comes down, which is a component of ERAS. Yes, sir, basically, yeah.
Okay, and maybe also as an operative team, you want to involve either vascular surgeon or
Yeah.
the thoracic surgeon, or maybe if it is a liver mobilization need, you are also need a hepatobiliary
Probably
surgeon.
involve the GI team. Yes, sir.
Basically, you want to have a good team and
Good team
experience.
and good backup available. Yeah. Anticipating any complication that can happen. Yes.
So that means in an operative aspect, you need to have a proper homework about the experience, skilled assistant, skilled scrub nurse, skilled technician, skilled anesthetist, and a whole skilled team in the OT operation theater. Am I right?
Completely agree,
With
sir.
all
Yes,
the,
sir.
with all the anticipated intraoperative events, right?
Yes, definitely, sir. Yes, sir.
Okay. And how this angioembolization may affect the fast track surgery?
Right, sir. So if we do embolize, sir, we are expecting that our blood loss intraoperatively will be less. Because of that, our operating time will be lesser. So basically, our entire intensity of surgery will come down. So it will lead to better outcomes, hopefully.
Okay. So, Dr. Sukta, in such cases, nutrition, pre-operative nutrition, either oral or IV, it has some specific, or as per the guidelines say, we do that, or surgery specific, we have to do this, we have to approach.
Yeah, so probably in this patient, because this patient is diabetic, so probably the standard oral carbohydrate loading probably is not a great idea in this patient. Plus his creat is high and he is posted for nephrectomy. So we want to avoid preoperative and perioperative dehydration. So if the patient is compliant, I would like to ask him to take water at least freely, night before surgery, also till 2 hours of till surgery. But if the patient is not compliant, if I feel the patient is not going to follow that, probably overnight a small maintenance pint of a balanced crystalloid, say 1 ml per kilo per hour is a good idea. And as Dr. Shivshankar said, if the patient is on insulin, sugar monitoring overnight is also very important.
Okay. So the bottom line of which I wanted to highlight for this question is that reduce operative time and reduce blood loss. I think these two parameters are the most important, other than the other parameters, which may influence positively towards the fast track surgery. Am I right, Aman and Dr. Sukta?
Yeah.
Yes, agree, sir. Yes.
Yeah. Oh. So treatment, we discussed anesthesia approach, position effect in fast track surgery. And intraoperative, already we have discussed about the additional surgical procedure intraoperatively, or maybe the local extensive disease. They may enhance the fast surgery because they may link with the more blood loss, more operative time, and as the surgical stress increases, the metabolic response also reduces, and that may negatively affect the fast track surgery. Am I right, Aman Sukta?
Yeah. Yeah.
Okay.
Yes, sir.
Yeah, so this patient underwent open right radical nephrectomy with IVC thrombectomy by midline incision. However, fast track surgery always favors towards the minimally invasive surgery, but in this case, minimally invasive surgery was not possible. So the principle was needs experienced team of urologist, anesthetist, plus minus vascular surgeon or any other hepatic surgeon or GI surgeon, whatever is needed as per the surgery. Again, the role of skilled assistant, the surgeons and anesthetist, scrub nurse cannot be overlooked. They are a part of team as a surgical management, and their importance should always be considered. So intraoperative GA was given, position was supine, surgery time approximately 8 hours, blood loss 2.5 liter. Only one PRBC was given, urine output adequate, patient extubated and shifted to ICU. Post-operatively, hemoglobin 10 and renal function tests were normal. So post-operative state, Dr. Sukta, just these upper three questions for you. Can you just answer one by one?
Yeah. So ICU stay per se, if this patient has had major blood loss and patient is getting monitored in ICU, probably the patient is hemodynamically borderline, requires intensive monitoring, probably cardiac output monitoring. So that means the ICU stay is going to hamper the recovery overall, because ICU means basically the patient's mobility is going to be hampered, as the patient might be hemodynamically unstable. Plus, the ICU stay increases patient's anxiety as well. So that is a factor which we need to consider as well. Pain management, of course, I mean, everyone has emphasized the role of pain management. So I don't need to, further go into the details, but extremely important pain management aspect. And probably till the patient is stable, shifted out of ICU and recovery to the wards and resumed on oral fluids. Till that time, there is a significant role of anesthetist, because we need to look after the IV fluid aspects also and pain management.
Okay. And also, maybe you also have to look after the side effects of pain management. Sometimes epidural patient may have lower limb weakness, and maybe the BP, blood pressure components are there. So you also have to look after. So till these things are normal, till you anesthetist has to look after the patient, right?
Yes.
Okay.
Yeah.
So Dr. Aman, which aspect a surgeon should focus post-operatively, and can surgeon anticipate delayed recovery?
Yes, sir. So talking specifically about this patient, we've done only a surgery which has removed something. We have not done any reconstructions. So basically, we can debate whether we want to place a drain or not. Because it's a major surgery with vascular involvement and everything, we might want to put in a drain. But then we would want to remove the drain as soon as possible. I'm assuming that this patient would have had a lot of bowel handling, but still, because we've not actually opened the bowel or done any anastomosis, we can probably take out his Ryle's tube the same day of surgery in the evening, or maybe the next day. Basically get him off tubes as soon as possible. The catheter can definitely come off the next day. Next day, I would be very happy to have this patient sitting up in bed, at least, if not walking. And maybe by afternoon, I can have this patient walking around, motivate the patient to do his spirometry, to do his chest physiotherapy, move around, move his limbs in the bed. And so he's off the RT, off the Foley soon. Drain, I'll probably take out once, I have noticed that there is no chyle coming in the drain, because we would have done a lot of dissection for such a patient. And yes, sir. And yeah, that's all, sir.
And can you anticipate delayed recovery?
Delayed recovery. Yes, sir. So I would on my own, even though I would want to do ERAS in all patients, as I said, always it may not be possible. And sometimes we would not want to push the patient too much, because then we go down a little and then we have to start from a back step. Such patients would be elderly patients, patients who've had a long surgery, patients who've had a lot of blood loss during surgery, patients in whom you've had an intraoperative complication, patients in whom you've handled the bowel too much and the bowel CD matters and takes time to come back. And the moment you are going on to ERAS, but you feel that the patient is not tolerating, I think it is always good to take just one step back and observe the patient and then probably start again.
Okay.
Yeah.
So you want to say that post-operative ERAS protocol is not cannot be applied to everyone. It should be individualized.
Yes,
right?
sir. And it cannot be very rigid also. It has to be individualized, sir. Yes, sir.
Okay, based on patient to patient and his post-operative recovery speed. Right?
Yes, sir. Yes.
So physiotherapy, I think on the previous slides we have discussed with Dr. Sarika. I want to say which one is there, how much and till when, till what time would you like to patient to continue physiotherapy?
Yeah, so our recommendation is usually we tell the patient to do it for 3 months and see this patient is having an abdominal incision. So this patient has to come back for his core strengthening after 3 months. So we will call him after 3 months, and based on his assessments done initially, that is a 6-minute walk test which we have done initially, we are going to give him an exercise program. And as you have said, the patient is already walking 5 kilometers. That means his capacity is very good. So if we have trained him at say around 80% of his heart rate reserve, then we are going to start exercising at 60% of his heart rate reserve after 6 days. Okay. Oh, sorry. Within the next few days, that is post-operatively 3rd day onwards, we can start training him at the level of 60%, 60 to 80% of his heart rate reserve. And if we feel that the patient is doing well, then probably we can switch over to say after 1 to 2 weeks to 80% of his heart rate reserve. So based on his initial assessment, it will be easier to chart a program for him later on, that is after the surgery, immediately. So immediately we are going to make the patient walk, and also along with that, we are going to make the patient do his respiratory training. So if he was using a spirometer before, or if he was using an IMT before, then it is better to start using those devices immediately after the surgery. And we advise the patient to use a spirometer for next 3 months, and unless and until he has any issues with his lungs, he needs to come back to us with the machine. And for any accumulation in the chest, then also we usually follow up till the time the patient gets discharged from the hospital.
Okay. So Dr. Shiva, I think the 2 questions you already answered. So does total parenteral nutrition, does it help in early recovery?
So TPN normally it never helps in the recovery. It can only sustain the patient to be in an anabolic phase. Nothing more than that it can be. Because once the patient is on a TPN, he is bedridden. Hardly, in 24 hours, he can be mobile for around maybe 30 minutes or maybe at the most 40-45 minutes, not more than that. So any patient who is not mobile, I wouldn't say the patient is in a recovery kind of a phase or any kind of a TPN would be eating. It is only going to be sufficing the basic needs of the patient's nutrition requirement, but not in recovery phase, the wound healing, reducing the inflammation and other things. We are expecting actually too much from the TPN. Of course, there are omega-3 fatty acids oriented kind of TPN solutions are also available, but they have limited outcomes of that. It can be just for the acute phase, we can just manage to maintain some kind of inflammation. But in the long run, I wouldn't say the recovery is going to be having around a week time of recovery. TPN is not the solution over there. But if the gut is available, TPN is always contraindicated. So let's better use the gut. And more or less, these patients are always available for their gut is always available.
Yeah. So as we discussed, we did everything what we have discussed, and this patient was discharged on the day 6. He was on full diet. On day 4, drain was removed, and day 5, and we observed for 1 more day, and patient was discharged on day 6. So team members of successful fast track surgery are the nurses, dietitians, physiotherapists, occupational therapists, pain team, anesthetists, OT staff, surgeons, and hospital management who can provide all these facilities seamlessly. The take-home message I would like to say for this panel discussion and this whole webinar was the fast track surgery is a concept and which has multiple dimensional effect, which reduces physical, mental, and economical stress patient and the family, reduces use of healthcare resources by reducing the time of the admission, stay in the hospital. It comprises counseling of the patient, careful assessment, and appropriate intervention by the multidisciplinary team. And multidisciplinary approach provides the optimal outcome and structured protocol for different specialties for different individuals, as there is a no one size fit to all in ERAS. And overall success manifests in the patient's eyes when he gets discharged early by saying us goodbye with the smiling face. Thank you. Thank you for the panelist.
Thank you, sir. Thank you for such a wonderful panel discussion that we had. Now I request the participants to post their questions or ask their questions. Sir, I think there is one question. What are the challenges that come across during routine clinical practice to implement compliance to fast track surgery protocol?
Dr. Aman, you want to take the question?
So usually, basically in the Western world, the doctors and everybody want, and the patients themselves want the patient to have minimum stay in the hospital for a lot of financial and logistical reasons. Our Indian patients, they love staying in the hospital, to be very honest. They would want to stay that extra day in the hospital. They feel कि सब ठीक हो जाए, सारे drains, सारे pipes निकल जाए, फिर हम घर जाएंगे. So it is a little difficult to convince them that they are all right and that they have recovered. And there are certain issues in recovery which have to be managed at home and which can be managed at home. And the thing is, the most important component of ERAS, which I told about mentally priming the patient, that is when you tell them that this is your expected hospital stay. So that from day one, they are knowing that they are going to be admitted for the hospital for X number of days, depending upon how their stay is, plus minus some complications. But they know that this is their stay. So that on post-op day 2, when you're saying all drains are out, you're on full diet, please let's go home, they are not shocked. Itne jaldi kaise ghar bhej rahe hain? So we need to prime our patients. But yes, we do face some problems. But it's about talking to the patient. It's about assuring them that you have done your bit, and now it is their bit and the relatives' bit to have some social support at home and complete the recovery process in home till we see them again in their next OPD visit.
So I would like to add in the same answer, if you do not advise as per the patient preference, suddenly you will become his enemy. Like that, because I saw one patient, we did robotic surgery, and he was fit to discharge next day. And when in the next day round, we asked, we are going to discharge him, he was surprised, like, so soon? Why? Abhi kali operation hua hai. Okay, so as Aman said, the pre-operative counseling of how the course going to happen in the hospital from the admission to the discharge and how much time anticipated in this is very important while to have a good compliance of the patient about the fast track surgery. Otherwise, they will feel that you are pushing them out from the hospital and they will take as a negatively. They will not take as a positive. So that is the very important. And our relation with doctor patient is all about sympathy. There's no empathy practically. It is only sympathy. They want sympathy. They don't want empathy. From we want to give empathy, but they only want, not deserve. They only want sympathy. So this was the answer. I think answer was okay. Dr.
Yes,
Devin?
Yeah, that's really helpful. Thank you, sir.
Yeah.
So anybody else having any questions, please?
Yeah, I'll
You
go
can ask.
for the questions.
Yeah, Dr. Niti.
That was lovely, Dr. Mahendra and everybody. I mean, very impressive. And it's amazing to notice how collaboratively the teams in the hospitals work, on a regular basis. I was curious to understand, like this is a multimodality concept. Are all the components of the multimodality fixed? And if they're not fixed, how is the outcome calculated? Like,
So basically, I understand, like you are looking at any partial implementation of the fast surgery protocol.
exactly. Like, so are these 5 components that you've listed out the components? If you had 4, is the effect is the synergistic effect, different from that of 5? Like,
so just Dr. Sukhda and Dr. Rasarika, everybody mentioned that it should be individualized. Suppose that any patient who wants to go hernia surgery, hernioplasty, and he's a young patient who is absolutely fit. Okay, so I think who is going to discharge by day 1 or maybe by the evening also. So I think other than his motivation toward the physiotherapy, one person can do. So here we can use prevent our resources. We can utilize in the more serious patients, because as we know, we have a very less ratio of doctors and the patient. So if we involve everybody in each patient, it is very difficult, the providers to manage. So
Mhm.
again, that I think that triaging is very important while involving the all the team into the surgery. Just like
Mhm.
in this case, if I would like to say, definitely in this case, we need all multidisciplinary team to be involved. And we would like to sit with for this patient together. But for the orchidectomy, for this thing, hernioplasty, appendicectomy, who's a daycare procedure, I don't think so we should involve everybody in that. But necessary if the treating doctor feels that that there is a need, at least 1 or 2 disciplinaries should be involved.
So, do you have complexity as a criteria? Like if the case is complex, so multimodal management hoga. If not, then
Yeah, we always in DMG, we have a DMG concept. So we sit together. And as I said, physiotherapist also comes in our joint clinic, and then they will decide if this patient needs special attention for the physiotherapy. Like if the patient is having hematuria, his hemoglobin is something 7, 8, and he is from village, his albumin level is, and he's very lean and thin, then definitely we will refer to the dietitian for the pre-operative worker, because we know he is going to be on the operation table after maybe a few weeks. So we have to prepare from that point only, not at the pre-operative period 1 to 2 days before. And Dr. Shiv Shankar already mentioned in his slide. In India, it happens that doctor referred to him 2 days prior to surgery.
I know you are sounding very unhappy about that.
No,
but-
it is there. It is there because somehow surgeon takes all the onus on them, unfortunately.
Which is true, which is absolutely true. So actually speaking, there are no contraindications to this.
No. If it is indicated, anybody should be this thing utilize our this multimodal approach on any branch.
Mhm.
Actually, I would also want to add that is where the role of auditing comes when we are using tailored approaches and different approaches for different surgeries. Probably we need to audit and see whether our interventions are actually helping or not.
Yeah.
So I want to understand, like I have a question, can I ask?
Yeah, sure.
Is this protocol applicable only in elective surgery or even in emergency conditions it can be used?
So,
Is there any sudden
yeah.
changes like that?
So emergency surgery patient, we do not get time to pre-operatively optimize the patient. But
Mhm.
definitely emergency, as Dr. Sukda showed a very good graph. If you see there's a one depression and it becomes shorter. So suppose that if it is also in emergency cases where the patient is already suboptimal condition, if we don't apply these approaches scientifically and logically, then the recovery will be going to be slower than the elective one. So definitely, I think in my personal view, fast track surgery principle should be applied more seriously in the emergency cases, post-operatively,
Okay.
because they need special care for early recovery, and their body is already under stress because of emergency water conditions are there. So they need special attention, but better than the elective one and more intense.
So maybe I sound a little, but अभी बताइए, what is the difference from a traditional surgery? Maybe we are supposed to, like a surgeon is supposed to be conferring with the anesthetist, who's supposed to be conferring with the, with the dietitian, with physiotherapist, and we are supposed to be doing it. So that we don't, maybe another issue.
So what is the difference between enhanced recovery of surgery than the traditional one? Little bit more boldness. More boldness. Boldness means removing Ryle's tube on day 1, allowing oral feeds day 1, not putting the drain even if something is done big like that. Early mobilization. Patient ko pain hoega, usko dard hoga, chalo rehan dete hain. No, and now we have very good pain management. Where even we have a big incision, patient doesn't have much more pain. It is very easily bearable pain for the physiotherapy. And definitely longer the hospital stay, more chances of hospital-acquired infections, pneumonia, all these things. So eventually everything is related to the patient psychological factor, financial factor, and physical factor. So as soon as, if I ask myself where I would be more comfortable, a 5-star hospital or my home? I will say my home, not even 5-star hospital.
So
Even-
when you talk about boldness, how often does this backfire? In the sense like, hata diya, day one
again,
pay, and then
again,
it's like.
Again, we discussed with Amandeep at the same question. It should be individualized. It should not be the shoes doesn't fit to all, one shoes. So it is our wisdom in which patient we should implement fast track strategy and how. It should be individualized.
Sir, one last question. So how
Yeah.
much fraction of surgeries that you do will be in the fast track protocol, and how much will be in the regular protocol? Like just an
70%.
approximation.
70%.
70% fast track.
70%.
Fast track surgery, yeah. Because because it start from the beginning. Because our focus is a pre-operative patient improvement, right? Obtention of the pre-operative optimization. During surgery, we try to have a minimal blood loss, minimal operative time. And again, whatever surgery we do until patient is old, where we think if we make him to walk, he may have some giddiness and fall, he may develop fracture. There we are a little bit slow. But young patient who is very motivated, educated, who understood this thing, we implement this day one.
Thank you, sir. I think in the interest of time, we can stop the discussions here. And if there are any questions from the participant, you can please send it to me by email. And you have a feedback form that will come up. Please complete that. And there also you have an option to send the questions. Then we will have it check with the panelists and then get back to you with the answers. And I thank Dr. Mahendra Pal, Dr. Sarika Mahajan, Dr. Sukada, Dr. Shiv Shankar. So all of you, Dr. Amandeep Arora. So all of you have vast knowledge, and I think it is my or our miscalculation on part of planning this webinar for 1 hour right now.
No.
I'm sorry for exceeding the time.
The topic was so huge. So
yes, sir. I think we need to have individual sessions for each panel member. I think even then 1 hour will be less.
But very well presented nonetheless, and wonderful to hear.
I think you have done an excellent job and you have concised everything. Each panel member has. I know what has been done in the back end, so it's tremendous effort, tremendous, absolutely.
Thank you.
And I'm wholeheartedly I thank all of you for sparing your valuable time and that too at this hour. And thank you so much. And I thank the participants also for staying so long with us.
Yeah, and thank you for my panelists for agreeing in very short notice and preparing the presentation in very short interval and a very impressive way.
Thank you, sir.
Thank you so much.
Good night.
Thank you and good night.
Thank you.
Yeah, thank you.
Thank
Good
you.
night. Good night, everyone.
Good
Bye.
night. Bye.